How to Pay for the Green New Deal by Yeva Nersisyan and Randall Wray. Universal Single-Payer Healthcare. The Universal Single-Payer System, or Medicare for All, is deemed the most expensive Green New Deal program. In a recent op-ed, Paul Krugman argued that heterodoxy, MMT, does not necessarily help advance the progressive cause because Medicare for All would be inflationary without new tax revenue. Krugman, 2019. However, the fact that he is analyzing whether Medicare for All would be inflationary rather than calculating how much it would add to the government's deficit demonstrates how MMT reorients the conversation away from financial and toward real resource considerations. In his critique, Krugman tries to shift the debate to what MMT has been saying all along, that government spending is not about financing, but about real resource availability and consequently inflation. Krugman concludes that Medicare for All could potentially raise GDP by 9%. Since labor markets are already tight, this extra spending would be inflationary, or the Fed would have to raise the rates, which could hurt investment. He then argues that, quote, rejecting conventional concerns about debt doesn't actually do very much, if anything, to make paying for progressive initiatives look easier. Even if you consider debt a meaningless number, the size of the things progressives are proposing means that pursuing those initiatives without an offsetting increase in revenue would create a lot of inflationary pressure. There needs to be new revenue to achieve what progressives, myself included, want to achieve. End quote. In the end, his analysis veers toward the need to add new revenue, although what he is really talking about is ways to offset the increased spending. For example, withdrawing demand, as Keynes explained, to prevent inflation. The reason why Krugman concludes that Medicare for All could be inflationary is because he does not take into account the potential savings from such a system. The U.S. healthcare system is notorious for its high costs and below-par outcomes. We already spend 18% of GDP on healthcare, and that is projected to reach 20% soon. This is approximately twice as much as our peers, other rich, developed, capitalist countries, with no discernibly better health outcomes, and even worse on a number of measures. Our excessive spending, when compared to that of our peers, can be attributed to the use of for-profit insurance to pay for health care, higher pharmaceutical and provider costs, largely due to prohibitions on or inability to negotiate for lower prices, due to multiple payers, and higher administrative costs, such as for billing. Study after study has confirmed that prices and administrative costs in the U.S. are out of line with those in the rest of the world, and especially compared with developed countries that have some type of single-payer system. In a 2003 study, Anderson et al., 2003, demonstrate that prices account for much of the higher healthcare spending in the U.S. Their more recent study from 2019, Anderson, Hussey, and Petrosian, 2019, confirms the results of the earlier study, despite all the reforms that have occurred since 2003, including Obamacare. The authors conclude that the U.S. was not then, and is still not now, devoting more real resources, hospital beds, physicians, and nurses, to providing health care compared to the OECD median. Nor do Americans receive more care. In fact, by some measures, they actually receive less care, fewer visits to physicians, for example. However, we are still spending more, a difference that is largely explained by higher prices. The 2019 study additionally demonstrates that the difference between prices paid in the private and public sectors has widened considerably since 2003. It is our greater dependence on private payers, rather than on government as single payer, that accounts for higher costs. Government payers actually impose discipline on the markets. Papadopoulos et al., 2018, reach similar conclusions. They report that their per capita pharmaceutical spending in other countries ranges from $466 to $939, while it stands around $1,443 in the U.S. Compensation of healthcare workers, such as nurses and physicians, is also higher in the U.S. $218,173 for a primary care physician, compared to a range of $86,607 to $154,126 in other countries. This could be due to a combination of entry restrictions to the profession, as well as inability or unwillingness of our private multi-payers to control costs. It is also well known that administrative costs in the U.S. are significantly higher than in any other developed country. For instance, governance and administration costs accounted for 8% of total national health expenditures in the U.S., compared to a range of 1% to 3% in other countries. Papadopoulos et al., 2018. See also Mueller, Hagenars, and Morgan, 2017, who calculate an OECD average of about 3%. Administrative costs on the provider side are estimated to be high in the U.S. as well. For instance, over 24% of U.S. hospital spending is on administration, compared to 12.9% in Canada. Woolhandler, Campbell, and Himmelstein, 2003. Adoption of single-payer replacing for-profit private insurers would significantly reduce the resources devoted to our unusual way of paying for health care. It would eliminate the private insurance sector's participation, reduce employers' costs of administering health care plans, reduce the costs incurred by doctors and hospitals due to billing insurers, as well as pursuing patients for uncovered costs, lower the costs of appealing denials, and cut costs associated with patients avoiding early treatment of diseases because of the actual or expected out-of-pocket costs that become chronic and expensive maladies. If Medicare for All could control prices and lower administrative costs, we could spend significantly less on healthcare than we currently do, while expanding coverage to everyone. While the distribution of spending between private and public sectors would change, causing a lot of anxiety about potentially ballooning government deficits, there is nothing about government spending that necessarily makes it more inflationary than private spending. All else equal, if spending on total healthcare costs falls by 5% of GDP, with private sector spending falling by 10% of GDP, and government sector spending rising by 5% of GDP, the net impact is deflationary. And what will matter is the overall increase of demand on resources while implementing all parts of the Green New Deal. If the healthcare savings offset increased resource use in other Green New Deal projects, then the net impact of the Green New Deal will not be inflationary. In the remainder of this section, we attempt to determine how deflationary the movement to single payer could be. There is a range of estimates for how much Medicare for All would cost, and consequently how much it could save or add to the nation's spending on healthcare. Woolhandler and Himmelstein, 2017, estimate high savings, around 2.28% of 2017 GDP, from merely reducing administrative costs. They conclude that hospitals and physicians would save $149 billion and $75 billion per year, respectively, while savings from lowering the insurance overhead and administration of public programs would be $220 billion per year. In recent testimony to Congress, Dean Baker presented savings estimates shown in Table 4. He estimates administrative savings for providers and employers of almost $5 trillion and savings on insurance administration of about $3.5 trillion over a decade. He projects further savings from controlling costs of care, including prescription drugs. Even with increased utilization of 10%, we are able to save $13.3 trillion over 10 years, which amounts to 4.5% of total projected GDP for the decade. There are other studies that estimate somewhat lower savings from single-payer insurance. Researchers at Perry predict savings of about 1.58% of 2017 GDP from Medicare for All, Poland et al. 2018. They assume an increased demand for health care of 12% from those who are currently uninsured or underinsured, and cost reductions of 19.2% of health consumption expenditures due to savings on administration, 9%, drug prices, 5.9%, applying Medicare rates, 2.8%, and cutting waste and fraud, 1.5%. Footnote 15. The category of underinsured includes people, quote, for whom out-of-pocket costs, excluding premiums, over the prior 12 months are equal to 10% or more of the household income. Out-of-pocket costs, excluding premiums, are equal to 5% or more of household income if income is under 200% of the federal poverty level, or if the deductible is 5% or more of household income. End quote. Poland et al. 2018. End footnote. Physicians in hospitals will achieve about 65% lower administrative costs, while the cost of administering the new single-payer insurance system will be 3.5% of total health consumption expenditures. In sum, annual health consumption expenditures would fall to $2.93 trillion from $3.24 trillion as of 2017, saving 1.58% of GDP. According to estimates from an oft-cited study by Charles Blahouse, 2018, from the conservative Marcatus Center, if provider reimbursement rates were lowered to Medicare rates, savings of $314 billion, we could achieve annual savings of 0.3% of GDP in 2019. Even with universal coverage without deductibles and copays and with added demand for health care, $370 billion. A further $70 billion and $50 billion, respectively, could be saved on administrative costs and pharmaceutical pricing. If, however, costs were not controlled, healthcare spending would increase by 1.2% of GDP. Since Blahouse estimates administrative and pharmaceutical pricing savings that are on the lower end of the spectrum, the majority of savings in the first scenario stem from applying Medicare rates to health services. Once that assumption is removed, it is not surprising that the net savings disappear. Blahouse has long been a critic of Social Security, so it is not surprising that his estimates of the cost of Medicare for All would hold up the high end of the range. We do not find his arguments persuasive, but note that even he finds potential savings if costs can be controlled. We use the savings from the studies described above to come up with our own estimates for potential savings from Medicare for All. Our approach is different from the others in that we start by eliminating the net cost of insurance and administration, both private and public, and then add an administrative markup to total costs at the end. The net cost of insurance, private and public, is the difference between health premiums earned and benefits incurred, CMS 2017. For example, according to the Centers for Medicare and Medicaid Services, in 2017, the net cost of private health insurance was $144 billion, meaning that the private insurance industry collected $144 billion more than what it spent on health care on behalf of its customers. After calculating health consumption expenditures with all the savings, we add a 3.5% markup to these costs for public administration of healthcare, a number that is in line with the OECD average. Once we find the total healthcare consumption costs after all these savings, we add another 10%, reducing the resource savings for higher utilization of the healthcare system. In Scenario 1, we use the Perry estimates, percent, for savings on pharmaceuticals and fraud and waste elimination. The estimate for savings from applying Medicare rates is the average of Blahaus, $314 billion, and Perry, $90 billion, at $200 billion. In Scenario 2, we combine Scenario 1 with administrative savings from Woolhandler and Himmelstein, 2017, discussed above, achieving savings of 3.67%. In sum, to our estimates, Medicare for All could save from 2.61% to 3.67% of GDP, depending on the assumptions, while providing health care to the whole population. We believe our assessment in Scenario 2 is a rather conservative estimate of the savings that would accrue from a Medicare for All system. The U.S. spends 18% of its GDP on health care, a number that is projected to grow over the next decade. The country with the next highest share of health spending on GDP is Switzerland, which spends a little over 12% of its GDP on health care. Thus, even if we lowered healthcare spending by 3.7% of GDP, we would still be spending more on healthcare than all of our peers, and a lot more than our neighbor, Canada, which spends 10.4% of its GDP on healthcare. OECD 2019. Some will object that the savings largely accrue to the private sector, while the government will face additional costs. This is true. We must remember, however, that the approach we take in this paper is to account for the net resource costs of a Green New Deal. Our argument is that it is the net increased demand on resources that will be inflationary. If private spending on healthcare costs falls by more than the increased spending by government, the movement to single payer will be deflationary, not inflationary. We do recognize that resources released by the shift from private insurers to single payer may not be well suited to alternative uses, such as other Green New Deal projects. Released resources will need to be retrained, and this can take time. On the other hand, increased use of healthcare could reduce the onset of chronic disease that results from inadequate early treatment, so that an initial boost to use of healthcare services will be followed by reduced need for care as chronic disease is reduced. It will take some time for these various processes to result in all of the potential savings and attendant deflationary pressures. With universal access, with elimination of a highly inefficient private insurance system, and with greater control over costs, the movement to single payer could shrink U.S. spending on healthcare by as much as 8% of GDP, bringing us in line with other rich countries at about 10% of GDP.